that women are disproportionately affected by Alzheimer's disease. And we know that once we approach and hit menopause, that's when symptoms tend to start. So on the website, we have devoted so much time and energy to trying to figure out, does hormone replacement therapy have a role in preventing or even reversing cognitive decline in the early stages? And you guys, if you've been on the website, we have a 43-page thread on this. And Dr. Ann Hathaway has read the whole 43 pages. So she gets like bonus points. Ann is a functional medicine practitioner. She has a busy practice in Marin County. And the first time that I met her, she was doing a presentation at Dr. Bredeson's MPI Cognition Physician Training, and it blew my mind. And from the moment I met her, I knew we had to have her talk to our community, because she does the deepest dive into hormones and cognition that I've ever seen done. And this time she's going to throw ApoE status in as well. So welcome. Thank you so much for making the trip. We're thrilled to have you.
I'm so happy to be here today. I love talking about hormones. It's a topic. You know, just what I'm thinking is that
good?
I have to
Step
I'd
back.
rather
How about a
look at the
chair?
audience than have to look back at the
How about
slides.
a chair? What do you think?
Well, she needs to look at her slides.
I know she does,
Yeah.
but I'm thinking that might be a little easier. What do you think?
Well, then how am I gonna? Sorry.
We can
Should've
no,
thought of this
we're
text.
fine. Oh, I've got an idea. Let me put some tablets on. We can read it. Nobody needs a room after us. We are fine. I was going to say, we could even raise it so you can see. There should be a podium. Perfect. And let's go ahead and raise it, and I can even put more talks if you want. How was that? Good. Better? And you could even bring this yourself. Good. Ta-da!
I think we're going to be very informal here.
Yes. That'll work.
Is this?
Yep.
Hi. Yeah, thank you so much for having me. Talking about the relationship between the brain and estradiol is a topic that is one I've been looking into, thinking about, reading the literature for over 20 years now. And so this group is, you know, you're the perfect group for me. So let's get into it. Here's the agenda. Estradiol improves cognition and reduces the risk of Alzheimer's disease. That's what I'm going to propose to make the case very strongly to you that this is true. So who is it that we should strongly consider for bioidentical hormone replacement? That's the other thing. I want to make sure that we all get a lot of clarity with regards to that. And thirdly, I want to talk a little bit about the bioidentical hormone replacement basics. Usually I'm giving this talk to physicians, but I think as a consumer, you know, as a person who is going to seek the best kind of bioidentical hormone replacement for yourself, and go into your physician with a lot of know-how and education about it, you're going to be able to pick out the kind of physician that's going to work well with you with regard to bioidentical hormones, because there's a lot of issues with regard to exactly what kind of hormone you use and how you use it. It makes a huge difference if you're using a synthetic or a non-synthetic, if you're using it orally or if you're using it on your skin. Of course, it's very important to know, in my opinion, your ApoE status. If you are an ApoE4 carrier, I think it's even more important for you to be aware of your estradiol level and have a good idea about what estradiol level you want to have to protect your brain after you've gone through menopause. Certainly, family history of Alzheimer's disease is very important. A history of major depression increases the risk of Alzheimer's disease. And any woman who has significant cognitive decline before age 65, if she's not on hormone replacement, I think she should be strongly considered for hormone replacement. Okay, so let's get into what's the evidence for benefit. There is a huge volume, a 40-year set of research, a large body of research, animal research and in vitro research. In vitro means outside of an organism, and clinical research. And this is the molecule that is our most significant molecule, 17-beta estradiol. No substitution for this will work as well as 17-beta estradiol. Our brain is full of receptors for 17-beta estradiol, especially in those parts of the brain that deteriorate with dementia. So, I'm going to propose that the following is true. Estradiol improves cognition and helps to prevent Alzheimer's disease. But if that's true, why is it that we're not hearing that, loudly? Why isn't everyone shouting that from the rooftops? And this is a very important question, because what you hear if you're in the pub or if you're in the salon is, oh, estrogen, that causes breast cancer. That's the general awareness of the public. And so we are going to talk about that constant elephant in the room, the breast cancer fear, the breast cancer risk, because that is a significant thing that everyone wants to and needs to consider. But I think that there is a tremendously poor understanding of the science by not just the general public, but by physicians in general. Busy physicians have a strong tendency to read the headline or read what we call the abstract, the article summary. And unfortunately, with hormone replacement, you have to read the entire article. You have to get into the nitty-gritty of what was done and how it was done to understand fully the science and make good decisions. I don't think I need to emphasize this here. I think that the ApoE4 community is well aware that women are at increased risk for Alzheimer's disease. The basic science is unequivocal. The animal studies and the in vitro studies are unequivocal about the benefits of estradiol for the brain. Clinical studies, observational studies, and what we call double-blind placebo-controlled studies, those kind of studies are problematic because all different estrogens and all different progesterones are mixed together in many of these studies. If it's an observational study, almost all of them will be mixing progestins, all different kinds of progestins. Those are all synthetic molecules, not the same real progesterone that our bodies make, right? And estrogen. Estrogen can be given orally or put on the skin. There's a huge difference in the results there. But you want to carefully evaluate the science, differentiate between oral and transdermal estrogen, between conjugated equine estrogen or Premarin, kind of estrogen, combination of estrogens that come from pregnant mare's urine, and bioidentical estradiol. all of those differences are huge. This article, the first one here by Whitney Wharton and her group on the potential role of estrogens in the pathobiology and prevention of Alzheimer's disease. If you want to read one good research article, I would recommend this one. She summarizes the case for estradiol in the brain extremely well.
Could you just hold it 1 second, just so I get it?
And what they conclude, this research group concludes from their very thorough, very systematic review of the literature, both the basic science literature and the clinical literature, is that if all women at the time of menopause were given estrogen replacement, that there would be at least a 34% reduction in Alzheimer's disease. I think if we were talking about bioidentical topical estradiol being a part of that picture and bioidentical progesterone, that this number would be higher. So what is the basic science research that gives us this profound set of data and information? So estradiol, as I said, there are billions of estradiol receptors in every brain, particularly in the parts of the brain that have to do with mood, memory, and various other parts of cognition. And the hippocampus, the amygdala, the basal forebrain, the pituitary, and the hypothalamus, those are probably names that you're familiar with by the end of this meeting. Those are areas where there's a very high density of estradiol receptors. These are the references for that group of slides. Estradiol has been shown to increase the density of pyramidal hippocampal neurons. Pyramidal are the main neurons, the large neurons that are associated with thinking and processing of information. Increasing the plasticity of synapses means the connections between the neurons are increased, right? The dendrites, the spines that connect one neuron to the other, and the links, the synapses between those dendrites and axons. And estradiol, I think this is particularly cool that mitochondria in the brain have a high density of estradiol receptors. That's the references for that last slide. And this is the estradiol and mitochondria slide. So there's a very significant relationship between estradiol and the mitochondria in the brain. There is increased oxidative phosphorylation, which means that we make more ATP. In general, if I was speaking to a lay audience, I would feel like I have to say what ATP is, but I figured you guys all know by now what ATP is, right? Okay. Cytochrome C is one of the molecules in the oxidative phosphorylation chain in the mitochondria. You need plenty of cytochrome C to produce ATP. Having more estradiol present reduces the production of free radicals by the mitochondria. The conclusion of this particular research study was that this data provides a plausible mechanistic rationale for estrogen therapy, reducing the risk of Alzheimer's disease. If there is a situation like a stroke, where there is a stopping or a blockage of the blood flow to a part of the brain, if estradiol is present, there is less damage to the brain and better recovery of the brain than if estradiol is not present. And after a stroke or other neuronal injury, if estradiol is present, there is increased recovery. Lipid peroxidation. So probably everyone here is aware of the fact that there is a relationship between cerebrovascular disease and the development of atherosclerotic plaque and the laying down of beta amyloid plaque, right? One enhances the other. If there's more what we call ischemic disease, vascular disease, more atherosclerotic plaque, that promotes more beta amyloid. More beta amyloid produces more atherosclerotic plaque. So estradiol presence at physiologic levels in the bloodstream will slow the oxidation of LDL. And you probably are aware that it's oxidized LDL that is much more likely to produce plaque. There's your references for that slide. And then estradiol has a very specific effect on beta amyloid. It reduces beta amyloid toxicity, it reduces the beta amyloid levels, it increases clearance of beta amyloid from the cerebrospinal fluid, and it reduces the amount of inflammatory response to beta amyloid. This is a diagram that I took from Whitney Morton's research paper, and it shows the way that APP, right, the precursor protein, amyloid precursor protein, can be broken down in various ways. And if estrogen is present, it promotes the cleavage at the alpha site in the depiction on the left. And when it is cleaved there, you produce soluble amyloid, which can be cleared by the cerebrospinal fluid. And estrogen's presence reduces cleavage or breaking at the beta and the gamma sites, so less insoluble amyloid is produced, the kind that leads to beta amyloid plaques. These are your references for the beta amyloid effect of estrogen. So, again, if the evidence is clear, why is it that this therapy is not utilized? Many of you are probably familiar by now with the WHI study, right? The Women's Health Initiative study gave us some valuable information, but in certain ways, it also set bioidentical hormone research way back. Their conclusions were mostly very negative. They reported an increased risk of breast cancer, heart disease, strokes, with Premarin, which is an oral horse estrogen, and medroxyprovera, right? So, it's important to realize that in the second arm of the study that was reported out 2 years later, the first arm of the study with Premarin and Provera reported out in 2002, and that study included the WIMS and the WISCA study. WIMS and WISCA were much smaller studies that looked at the results of Prempro, this combined product of Premarin and Provera, right? That all the women in this particular part of the study were given. Again, this was a subgroup, and all of them were over 65. All of them were hormone naive. In other words, they'd never been on hormones from the time of menopause up until age 65. And all of them were given this combination of Premarin and Provera. Both WIMS and WISCA concluded that Premarin and Provera increased the risk of Alzheimer's disease. Why were these studies, so negative about the cognitive impact of Premarin and Provera? Okay, so medroxyprogesterone, you need to understand, is an extremely unbeneficial hormone. It has multiple negative effects on the brain. And we'll go into that further in a little bit. Premarin, given orally, is a mixed bag, but in women over 65 who are hormone naive, in other words, they've been without estrogen from age approximately 50 until 65. During that time, what happens with the lack of estrogen is the tendency to develop atherosclerotic disease. Then you add Premarin in. Premarin increases C-reactive protein, an inflammatory molecule, and increases fibrinogen. Fibrinogen increases the tendency of the blood to clot. So you have inflammation, as evidenced by increased C-reactive protein, and you have increased fibrinogen. And what does that predispose you to? Heart attacks and strokes. Yeah. Okay. This is an observational study. In general, observational studies are problematic because they're very prone to bias. But I just want to show you this study as a comparison to WHI, right? Because in this study, they looked at death certificates and they looked at whether there was dementia or Alzheimer's disease mentioned in the death certificate. Then they went back and looked at whether they were on hormone replacement or not. And what they found is women who were on Premarin, some of them were on Provera with it, some of them were not. We don't know how many. We don't have that information. But the point is that women who were on Premarin for greater than 7 years had about a 50% reduction in their risk of all-cause dementia. I think this is a significant study, and it shows the difference between WHI, where you're starting women at age somewhere between 63 and a half and 65 on hormone replacement, or everyone over 65 in the particular in the specific cognitive studies, and women who, in this particular study, most likely these women started hormone replacement on or close to the time of menopause. You get an extremely different result. So, as you can see, this is my main point here. Estradiol is not conjugated equine estrogens. Premarin is about 80% estrone plus 8 to 10 other conjugated equine estrogens, a mixture. Progesterone is very different than medroxyprogesterone. As you'll see later, progesterone has a lot of beneficial effects. Medroxyprogesterone, not so much. So, best practices, estradiol versus estrone, no contest. Also, transdermal versus oral. Transdermal is always better than oral. So this is a group of cognitive studies. And again, this is from Whitney Wharton's paper. On the left are the studies that used estradiol, and on the right, the studies that used some form of estrone. Most of the time, it was Premarin, okay? And all of these studies were ones where they compared before and after on the hormone, some kind of cognitive testing, and after the hormone. These were, in general, these were small studies, but these were placebo-controlled trials. So they measured all different kinds of cognitive things, verbal memory, visual memory, all kinds of different things were measured in these different studies. But with the estradiol studies, you can see that the preponderance was that there was a positive result. There was a benefit, and none showed harm. But in the estradiol studies with benefit, to 15 out of 20, 14 out of 20 were transdermal estrogen, right? In studies with no benefit, 3 were oral estradiol, and 1 was a very ultra low dose estradiol patch. I took out one study, you'll see if you look at this article, where they tried estrogen in men to see if that improved their cognition, and that did not benefit the men. I don't know that that's a definitive answer right there, but
Interesting.
it was just one study. And as you can see in the estrone studies, they got about 50% showed benefit, 50% no benefit. 3 showed harm. Why did they show harm? Because they started women who were 65 on Premarin and Provera. Okay? So now I want to talk about a set of studies that I think are very, very important. One thing to be aware of is that the WHI study has had a very negative effect on research. It's hard to get research approved now because the assumption by the institutional review boards that have to approve, yes, the study is ethical, yes, the study is a good idea. Well, if we already know and accept that estrogen causes breast cancer and estrogen doesn't improve cognitive function, estrogen doesn't prevent Alzheimer's disease, then it's become very, very difficult to get these approved. But some very good scientists are finding ways to get around this. And so I'm going to review these small studies because I think they're very instructive studies. And this set of studies was done by a multi-centered group of people, UCLA, Stanford, UC San Francisco, and some other medical centers. So 53 postmenopausal women, all who had increased risk, one way or another, of Alzheimer's disease, had been on estrogen-containing, some form of estrogen-containing hormone replacement, on average 9.5 years. And they did before and after FDG PET scans, these very high-tech PET scans that look at what kind of activity, glucose utilization there is in the brain, right? And this is just the preliminary data on the women that are coming into the study. What they found, if they'd been on estrogen more years, they had improved preservation of specific areas of their brain. Women on estradiol, in their particular group, performed 3 standard deviations better on verbal memory than the women on Premarin. And they saw on the PET scans that the improved memory did correlate with increased activity in the part of the brain that the Wernicke's and auditory associated areas. However, if they were on medroxyprogesterone with their estrogen, they showed decreased temporal brain metabolism compared to the women on estrogen alone. So what they did is they took half the women, after they'd done PET scans on everyone, half the women went off their hormone replacement, half the women stayed on their hormone replacement, okay? These same 53 women, some ApoE4, Alzheimer's disease, family history, history of major depression. So they were on standard kinds of estrogen replacement, either transdermal estrogen with a progestin, Premarin, with a progestin or estrogen alone. And of course, I think most of you know that you can be on estrogen alone if you've had a hysterectomy, right? But if you still have a uterus, it is advised that if you're on estrogen, you are also on a progesterone. So, half continued their hormone therapy, half discontinued. 2 years later, they restudied these women with PET scans. So what they found, both Premarin and the transdermal estrogen showed some preservation of multiple brain areas. And of course, these are the areas that we're familiar with that deteriorate in Alzheimer's disease. But transdermal estradiol showed a particularly protective effect that Premarin did not. It protected the posterior cingulate cortex, which is an area of early degeneration in Alzheimer's disease. And by the way, just we'll get into this a little bit later, but the average estradiol in this study, the average level, was 36 picograms per mil. And as you can see, there was a very big range, plus or minus 30 picograms per mil. So again, our culprit, medroxyprogesterone. If medroxyprogesterone was present and added to either the conjugated equine estrogen or the transdermal estradiol, deterioration occurred in several areas, right? Unfortunately, only one woman in the study was on real progesterone, oral micronized progesterone. So we don't have data from that. Hopefully, we will be getting some data on that coming out because this group, Rascon and Natalie Rascon, who was the first author in this study, and several other people that she's working with are trying to move forward with more studies of this type where oral micronized progesterone will be included. Some of the ways that medroxyprogesterone is very deleterious, there's a lot of research that demonstrates that. Estradiol upregulates mitochondrial function, but medroxyprogesterone blocks that upregulation. Okay, the ApoE4 telomere study, and I didn't even realize this when I was first reading this study. This is the same group of women.
Oh, really?
Interesting.
This is the same group of
Telomere
women.
women.
Emily Jacobs is at UCSF, but you'll see that Natalie Rascon is also an author here. And in the preliminary research I'm reading, and I'm like, this sounds very familiar. This is the same, we have mined the data from these 53 women very, very successfully.
There were a lot of ApoE4s in that group.
Right. They picked, the women they picked for that study were, they picked women who were high risk for Alzheimer's disease. So they ended up with a number of ApoE4 women. They don't say anywhere in there whether there are any ApoE4 women in there, by the way. I'm gonna try and talk to them and find out about that. But I think some of you here are familiar with this, the telomere study, right? So tell me. Anyway,
Convinced me. That's the one that convinced me.
Yeah, me too.
yeah. Well, telomere length is one way to look at the health of a cell and aging in a cell, right? And that's what this study, and Emily Jacobs she's a telomere researcher, and she piggybacked onto this group doing this comparison of continuing versus discontinuing hormone therapy, right? Anyway, they had 42 ApoE4 people they had 18 ApoE4 people who completed the study with the telomeres. And as I think those of you who are following this know that the ApoE4 carriers, on average, they decrease their telomere length over 2 years, equivalent to about 10 years of additional aging. And they lost an average of 435 more base pairs than non-ApoE4 carriers. Base pairs, DNA is made up of individual base pairs, right? But if they were on the hormone therapy, they did not exhibit the shortening of the telomeres. They either stayed the same length or they only lost a couple of base pairs. So, very, very interesting study. I always like to talk about this trial. Again, we have a lot of these very good studies that are very small, but I think they're important for our work. And these were 2 different studies, both by Asthana, where 20 women with moderate Alzheimer's disease. These were not, real early stage Alzheimer's disease patients. They were full diagnosis of Alzheimer's. And they were not on any hormone therapy. Then they were put on the highest dose of the transdermal estradiol patch, the 0.1 dose, or a placebo patch for 8 weeks. And then they had cognitive testing, and they showed significant improvement in attention and verbal and visual memory. And also, their caretakers were asked to give an evaluation. And they also, the caretakers also said and noted significant improvements in their ability to comprehend, their alertness, their attention. And the study only went 8 weeks. They did a crossover study. They got the same result when they crossed over, put the women who had been on the patch on the placebo, put the women who had been on the placebo on the patch. They got the same result. These women had their estradiol levels, fairly high, up in the 100 picogram per mil range.
And do you know the average age of these women?
I don't.
Alzheimer's age.
I think probably the majority were Alzheimer's age. Yeah. Yes.
Were they also put on progesterone or just estrogen?
Just estrogen. Yeah. Just estrogen.
And is the 100 kg per mil, is that kind of what we see in the serum levels? Is that a typical serum level?
So in my practice, we're going to talk about this a little bit.
Okay.
In my practice, I don't typically go that high.
Yeah.
If someone had premature menopause, I would,
Right.
right? If someone was in their 40s, they had early
Sure.
menopause, either surgical or otherwise, I would go higher, maybe even up to 120
Mhm.
during the 40s. Yeah.
Would you use it on someone that had estrogen receptors in cancer?
We're going to talk about that. But with provisos and with, very close following, and I would, and I do, treat post-breast cancer women with hormone replacement. Yeah. And estrogen receptor positive, almost all breast cancers are estrogen receptor positive. So when we're going to talk about hormone replacement, there's a lot of things we're going to consider. Of course, cognition and dementia prevention are part of it, but there's a lot of other benefits or potential risks with hormone replacement. Estrogen has a big effect on mood, sense of well-being, quality of life. It affects sleep. Women don't sleep well when they're having hot flashes and night sweats. Estrogen has an important effect on sexual function, improving it. Osteoporosis is much less likely on estrogen replacement. Cardiovascular disease prevention is significantly a part of it. And then, of course, breast cancer prevention, breast cancer risk has to be considered individually for each person. As I'm sure you can conclude from my presentation, I only use estrogen on the skin. I'm not a believer in troches. I think I had a woman come to me with a troche.
What is a troche?
Well, compounding pharmacies can make up something that dissolves in your mouth. And theoretically, it's absorbed through the mucosa inside your mouth. The problem is some of it is going to be swallowed. And when you swallow estrogen, you get this first pass liver effect. And one of the effects of that can be a very high estrone. So the particular woman who came to me, she had a nice estradiol level of 50, but her estrone level was over 200. It was just a ridiculously high estrone level, and her sex hormone binding globulin was over 1,000. The sex hormone binding globulin should be somewhere between 120 and 160. So,
They're trying to get you back up.
oh, I didn't know I went down. Thank you.
Yeah, we don't know. We're having a blackout.
Yeah.
Do you want me to wait?
Well, you may want to. Can you see your
I
slide?
can see my slides. I can
Okay,
keep going.
if you think, yeah, if you think we can follow, yeah.
We can follow.
Okay.
I mean, you guys are gonna have access to the video.
I was gonna say, we're gonna
It's
get
gonna be-
copies,
It's
right?
gonna be on,
Sure.
it's gonna be on the website,
Sure.
That's good.
but this won't be on it. Are we recording?
Yeah, it's okay. Yeah,
Are you
we're
gonna
very
edit the
casual. We
recording?
can edit, we can edit. Yeah, it's okay. We're very cool, very
And when you
chill.
put your PowerPoint up, that's okay.
Sure.
No, I mean,
On the website,
Oh,
sure.
So you can have the slides out.
Sure.
We're gonna be back up in a couple minutes, but go ahead and go on.
Okay, well, anyway, so there's commercially available gels, Divigel, Estrogel, those are good choices. There's lots of patches. Some women really like the convenience of the patch. Some women hate the patch. They don't like having something, plastic stuck on them. But those are all good choices. Probably about 65-70% of my practice uses a cream from a compounding pharmacy. The advantage of the cream from a compounding pharmacy is that you can increase or decrease the dose really easily. You have a little syringe with a lot of little markers on it, and hey, we're a little bit low, so you can go up a little bit, or you can go down a little bit. So I like the the flexibility of that kind of dosing. But those are all, certainly decent choices. We're not going to be able to talk about every single thing, but I just will mention that Estradiol is a weak estrogen that is used for atrophic vaginitis. Extremely effective. The Estradiol is a weak estrogen systemically, in other words, in the rest of the body, but it's very strong on that vaginal mucosa. So it increases the thickness of it, it increases the elasticity, and it increases the secretoriness of that tissue. So it's a very good choice, and that's only available via compounding pharmacies. I'll just mention here, since we don't really have much time to talk about testosterone, but I do prescribe testosterone as part of my bioidentical hormone treatment. Not for everybody. It's not absolutely necessary, but for some women it does make a big difference in terms of libido, in terms of sexual function, in terms of for some women, muscle mass, endurance, strength, etc. So that's something to be aware of that is only available in the United States via compounding pharmacy.
Right.
Canada has a product available for women, a topical testosterone. In Europe, they have a topical testosterone available for women. In the United States, no.
I thought I used something called Testim. You know what I'm talking about? TESTIM?
Was it a product made for men?
Oh, I don't know.
It's a 1%.
Yeah, there's a lot of
Okay.
products, there's a lot of testosterone
Okay.
products in the United States made for men.
Oh, how funny. I had to go to a secret pharmacy and just put one little drop on.
Uh-huh. Yeah, yeah.
Okay, and the pharmacist winked at me. No, I'm kidding.
Yeah, you could theoretically use the products that are
Okay.
made for men and just use
Sure.
a very minute amount.
Okay. I think
You know,
yeah, I think
But I don't think that's the best way to handle it.
Okay. That's what my doctor had me do.
Okay, so then we have a number of issues that come up when you're prescribing estrogen or when you're using estrogen, right? Sometimes you're using estrogen, yet you're still having symptoms of low estrogen. You're having hot flashes and night sweats up all day and all night, even though we might measure your estrogen level and wow, it looks okay, So what can happen is there are a number of things that will alter your estrogen metabolism. Alcohol is a really big one. When you drink alcohol, it will temporarily block your body's processing and removing the estrogen from your body because it'll prioritize removing the estrogen, and here your estrogen level goes up, and then your body finishes, maybe it's 3 in the morning and you're sleeping, your body finishes processing the estrogen, but those enzymes that have processed it are revved up and ready to go, and so what do? They start processing the estrogen, your estrogen level goes whomp, like that, and all of a sudden that rapid decline in estrogen level can cause a very severe hot flash or night sweat. So some women have to give up alcohol or go to extremely small amounts of alcohol. The other big problem with unstable estrogen levels is polypharmacy, what I call polypharmacy. If you're on a sleeping pill and an anti-anxiety pill and an antidepressant, the likelihood is that a number of enzymes that process all of those pharmaceuticals will be, again, revved up. And that will, again, in some women, really interfere with the stability of their estrogen level. So a lot of times we have to really work hard to taper people off their anxiety medicine, switch them to more natural products. We have a lot of natural products that we use that are successful for reducing anxiety and helping with sleep, etc. When some women will be prone to a high estrogen level, when I'm giving compounded estrogen to women as a cream, generally it will contain estradiol and a little bit of estriol, no estrone. Originally, in the early 90s, when compounding pharmacies first were around and we were doing estrogen replacement, it was triest. It would be estradiol, estriol, estrone, that combination of hormones. But we realized over time the estrone was deleterious. Estrone is the form of estrogen that women continue to make after menopause because it can be made outside of the ovary. We make androstenedione in the adrenal gland, and that can be converted by aromatase enzymes, which some of you are very familiar with aromatase enzymes. That can be converted in the fat tissue to estrone. And estrone is considered a less favorable estrogen. So we definitely don't want to have a high estrone. That's one of the mistakes I see in a lot of bioidentical hormone practices. They measure the estradiol, they measure the progesterone, they measure the DHEA, they might measure the pregnenolone, but they don't measure the estrone, and that is a very important thing to keep an eye on, because you do not want to let that estrone get out of hand and too high. You can have an estrogen dominant effect from a very high estrone. So, progesterone. All women who are on estrogen and have a uterus need to be on progesterone, because estradiol, or any estrogen, grows the uterine lining, and progesterone reverses that growth. If you don't have progesterone around, you can get hyperplasia, or a form of overgrowth of the uterine lining, and that can turn into uterine cancer. Progesterone will very effectively prevent that if you have a sufficient progesterone level for your estrogen level. Thank you.
Sorry, can I just?
So, in my practice, most of the time I cycle progesterone, part of the month on, part of the month off. Most of the month on, somewhere between 18 and 24 days on progesterone, the rest of the month off. That's optional. It doesn't have to be that way, but the advantages of that are that your progesterone receptors are more sensitive that way. Progesterone receptors in our reproductive part of our life, they're only exposed to progesterone for about half the month, half of our cycle, right? So progesterone receptors are kind of set up to be stimulated and then have the stimulus removed. And so progesterone receptors function a little better with the stimulus part of the time and the stimulus taken away the other part of the time. Some women have trouble with that because they sleep much, much better on the progesterone. And if that's really the case, sleep will trump it, and I will just keep them on their progesterone. The other thing about progesterone compared to estrogen is that progesterone is a fat-soluble molecule that builds up in our tissue over time. So over the 15 to 25 days that you're taking the progesterone, the level gradually rises. Whereas the estrogen is in and out of your body pretty much every day, at least every 36 hours it's gone. So that's something else you have to watch. That's why progesterone levels have to be measured regularly to make sure you don't have a sky-high progesterone level. With a sky-high progesterone level, you can get either extreme sedation, or actually you can get the opposite. Progesterone can all of a sudden start going down a pathway, that a metabolic pathway that turns it into cortisol. And all of a sudden, you get a very high cortisol and the person isn't sleeping. I've had this several times with patients where they love their progesterone. They keep taking a little bit more because they just feel more relaxed and they sleep better and they take more. All of a sudden, one day it happens, they're not sleeping at all. And that's, you know, they've turned that switch and their progesterone is all of a sudden going to very high cortisol levels. We always recommend taking your progesterone at bedtime. As I said, it can be very sleep enhancing. The downside of that is that some women are very sedated, tired, brain foggy, etc. on progesterone. And that is about, I would say, somewhere between 15 to 18% of my patients have this intolerance of progesterone phenomenon that we have to work with. And a couple years ago, I ran into a treasure trove of Scandinavian research. And it's really helped my practice a lot, because what they found was that if you use your progesterone vaginally, for most of those women, they will not get that extreme sedation, they will not get brain fog, they will not get depression, they will not get fatigue. The metabolism is different, and it would take days to review all the detailed data on what happens with progesterone in the brain, but it is quite complex. But suffice it to say, the exact same oral micronized capsule of progesterone I have found can be used vaginally. There are special suppositories that can be made, but the suppositories are a lot more expensive. So just making up the oral capsules and using them vaginally doesn't work for every single person, but I would say of those who don't tolerate it, we're having about an 85% success rate. This is a chart of suggested progesterone levels for a given estrogen level. And since in general we want to be in the estradiol level between 40 to 80, and by the way, there is no good literature on this. There's no literature that talks to us and says, yes, this is a good estrogen level that will protect the brain. That's why I showed you in those studies what the estrogen levels were, just to give some idea. The Stanford Natalie Raskin study, they found a level of 36 plus or minus 30. Those women showed significant brain protection. But would they have been more protected at a higher level? Would they have been just as protected at a lower level? We don't know. So this is all just extrapolated from my own experience. I've been prescribing bioidentical hormones for 22 years now, and everything that I can read on it. And this is what I've come up with for approximations of safe levels of progesterone for a given level of estrogen. And I have found that when you have a higher estrogen level, you do tend to tolerate a higher level of progesterone.
And you had that one study where I think they were reversing cognitive decline, improving it with 100.
With 100, yeah.
That was pretty
Right,
high, yeah.
Right. That was a high level. And did they need that high of a level?
Who knows?
That's the only level they tested, right?
Right.
I mean, studies are expensive. And
Right.
you know, it's hard to get them funded, right? So I tend to have women test their estrogen at a specific time, so we get a mid-level, the middle day of the patch, if they're on the patch, or 8 to 12 hours after the last dose of estrogen has been applied. And if they cycle their progesterone, I have them do it the day after they've taken their last progesterone, because we want a peak level. The levels that I gave on that slide before, those were the peak level, the level at the end of the progesterone. Or if you're taking it continuously, you would want to be approximately at that level.
Could you just say that again on the progesterone in this, or if you're taking it all the time?
If you're taking it all the time, you still want to be at those levels in the slide a couple slides ago. Compared to your estrogen level, you know, say your estrogen level is 40 to 50, right? Then you want to have a progesterone level, you know, approximately in the 3.5 to 4 range, right? So you have enough progesterone around so that your uterine lining is protected.
And when are you checking are you checking the progesterone level at the same time as the estrogen level?
Yeah, if you're on progesterone all the time, then you can check the progesterone anytime,
Together? Yeah.
right?
Just check.
And you just have to time the estrogen. Yeah.
Can you say what you think is the best level to maximize cognition, just in general? Like, would you say you shoot for 80 to 100 for somebody mid-70s? Or is no?
I don't know. I honestly don't. I wish we had research, you know. But in general, I aim for a level between 40 and 80, and I see how people do it. Except in people who are between 40 and 50 or even younger. Then I would put them over 100. Then I would put them up at, you know, something like 120. Yeah.
But probably if you're not having a problem, 80 would be good. Like the high, or no, not necessarily.
You mean someone who's not, a woman who's not cognitively impaired?
No,
What-
a woman who is cognitively impaired, like if there's not a drawback.
Right.
Does it help to keep pushing it up?
It might, but when you push it up, then you do run more risk of things like breakthrough bleeding, breast tenderness. You can run into issues like that. So, that's why I say 40 to 80. I think for many women, 40 to 50, they will get a lot of benefit. That's what I'm seeing clinically. Is 80 better? Maybe. I don't know. We need a huge randomized trial to tell us that, right?
What about the whole phenomenon of, as you said, 40 to 50 would push it above 100? So what about the phenomena of estrogen dominance in the perimenopausal woman? Would you adjust that? Would you still keep it above 100? Women are
So
coming
in-
with,
In
breast
estrogen
tenderness.
dominance,
Yeah.
there's a couple, that's a term that has a number of different meanings, right? I've seen some women with estradiol and estrone levels over 500, right? In their 30s, in their 40s, and in their early 50s if they're perimenopausal. I consider that to be not good, right? But sometimes, regardless of the estrogen levels, you have these estrogen effects. And that kind of tendency to feel for bloating and breast tenderness and all of that. And that is primarily, in my opinion, a xenoestrogen effect, an effect of the toxins in our environment. Phthalates, which are in plastics, bisphenol A, organochlorines, hydrocarbons, all the toxins that we're exposed to, many of those act as estrogens. They bind to our estrogen receptors and stimulate them in a way that is very unfavorable and unhealthy, right? So I think that's estrogen dominance, I think of primarily as a toxic xenoestrogen effect.
Would you offset that with progesterone? Would you, just in terms of, because what could you do in the, if we're looking at that terrain then of the woman in perimenopause, would you offset that with, looking at levels, if the ratio is higher in estrogen, lower in progesterone, would you increase with progesterone?
Oh, yeah, absolutely, yeah, certainly, yeah. Okay, talked about the timing. So we've kind of gone over this. There's many avenues for obtaining good oral micronized or good safe progesterone. There's commercially available progesterone. Oral micronized progesterone. It used to always be in peanut oil. I've recently been told that it's not in peanut oil. I'm not 100% sure about that. So I would be careful if you're peanut allergic. But that only comes in 100 milligram and 200 milligram doses, compounded from a compounding pharmacy. You can get oral micronized progesterone in any dose you want. There's over-the-counter weak progesterone creams, 20 milligram per quarter teaspoon, but some perimenopausal women use this and benefit from this if they're trending toward being estrogen dominant. Some women in their 40s are cycling but not ovulating, so they're making estrogen but no progesterone, and they can benefit from progesterone. And then there's compounded progesterone creams. You can get them at very high doses or low doses. And then there's vaginal suppositories, there's mini inserts, there's high-dose suppositories. And as I said, what I've come to usually, because it's much less expensive, is just getting the capsules in the optimal dose for that woman and using those vaginally. There's a few extra things about progesterone that are of interest, possibly. Some women will find that there's a particular dose of progesterone that protects them from migraines. Progesterone does have a muscle relaxant effect. Progestation, one of the effects of progesterone toward the end of pregnancy, when you're getting ready to deliver, the muscle relaxing effect of that very high progesterone level is part of what allows the baby to pass through the birth canal. And as I mentioned earlier, some women do find that progesterone is absolutely essential for them for sleep.
I have a quick question. If you're getting benefit for sleep and you don't have a uterus, is it still a good idea to cycle progesterone?
If you get enough benefit
Uh-huh.
and you sleep well,
Uh-huh.
cycling, then I think that's probably a good way to do it. But if
Okay.
you don't sleep,
Got it.
when you go off the progesterone, I
Got
would
it.
still keep them on it, even without a uterus. And
Okay.
you make a good point, which is that I have a lot of patients who are, post-hysterectomy for whatever reason, who are on progesterone
Sure.
as well because of the significant benefits. Yeah, yeah. Okay, breast cancer. This is, of course, a huge topic. I'm sure you're going to have some questions on it. There is no significant body of research that answers the question, with transdermal estradiol and with bioidentical progesterone, is there an increased risk of breast cancer? Okay, there is one double-blind, placebo-controlled study using transdermal estradiol patch and oral micronized progesterone. That's the KEEP study, reported out in 2014. There was no increase in breast cancer. It was a 4-year study, 750 women, 0 increase in breast cancer, right? And the other study that I always point to when the question of does estrogen increase breast cancer risk, whenever that question comes up, the WHI study, the second arm of the WHI, which came out in 2004, 2 years after the Premarin with medroxyprogesterone, the Premarin alone arm of the WHI showed a decreased risk of breast cancer in women on Premarin alone, right? Decreased by 7 women per 10,000 women per year. And 10 years later, they reevaluated those women compared to the controls. The controls got a placebo Premarin pill, right? And they had a persistent decreased risk of breast cancer as evaluated again in 2014 compared to the women on placebo. The women who were on Prempro, by the way, their increased risk of breast cancer was not huge. It was 8 women per 10,000 per year. So the decrease in breast cancer risk on Premarin alone was almost as large as the increase on Premarin with medroxyprogesterone. Okay? So those are the only 2 double-blind, placebo-controlled trials that we had, and neither of them say that estrogen causes breast cancer. What we have in the literature in terms of, saying that estrogen increases breast cancer risk is a lot of very large observational studies. And as I said earlier, I am really not a fan of observational studies. They are really prone to bias. And a double-blind placebo-controlled trial will trump a huge observational study any day, in my opinion. But this is an observational study where they actually compared women who were on estrogen alone, women who were on estrogen with a synthetic progesterone, and women who were on bioidentical hormone replacement with micronized progesterone, right? So what you can see here is a lot of numbers in the study, but down at the bottom, 0.9 with oral micronized progesterone. So a number 1.0 would represent no change between someone not on hormones and whatever the change was. In this case, estrogen plus oral micronized progesterone, they had a decreased risk of, they had 9/10 the risk of someone who was on nothing, right? If you were on a synthetic progestin with your estrogen, your risk went up 1.4 times. I'm going to skip that second slide. More on the French study. Okay, so here's what I do in my practice for breast cancer prevention, right? Obviously, I don't use any medroxyprogesterone, and I only use topical estradiol. So, high and varied intake of low-carb vegetables, especially cruciferous vegetables. Cruciferous vegetables alter the metabolism of your estrogens. I'm going to show you where they act. Indole 3-carbinol and diindole methane, maybe you've heard of those, but those are some of the active ingredients in cruciferous vegetables that help metabolize your estrogens in a favorable way. Of course, we want you to eat organic, unprocessed food, non-GMO, no trans fats. Have an appropriate BMI. I would probably change that to 18 to 22. Lower insulin resistance, lower your hemoglobin A1C, have your insulin be 5.5 or lower, and your fasting blood sugar should be ideally 85. Adequate exercise also reduces your risk of breast cancer. This is what I suggest to my patients. Alcohol increases the risk of breast cancer. Sorry to tell you, those of you who love your wine, but one drink a day increases breast cancer risk by 10%. Obviously, avoid tobacco. Having an optimal vitamin D level is protective. These are the levels that I recommend. Adequate selenium and adequate iodine also are important in breast cancer prevention. If you eat only sea salt, you may want to consider adding kelp capsule or getting some nori and crumpling that up on your salad a few times a week.
There's iodized sea salt now.
Oh, really?
Yes.
Okay. All right, I'll have to look into that. B vitamin support, especially methylation, is very important in how your estrogens are metabolized. And of course, as we mentioned previously, avoiding all the xenoestrogens. Bisphenol A is in every receipt that you get from the bank or the grocery store. Phthalates are in all plastics. Organochlorines, unfortunately, are in our non-organic food. Hydrocarbons are in the exhaust of every engine. And parabens are in most makeup unless you get EWG approved. And hopefully you guys know EWG, right? I'm sure it's recommended on the
I've
site.
got a quick question. Do we really need an annual mammogram?
Oh.
I like that one.
Because I just hate the radiation.
Yeah. Well, I send my clients for ultrasounds.
Yeah.
I
instead.
prefer that, yeah.
But
Yeah.
most gynecologists, they want both. At least I keep getting, they want both the
Right.
mammogram and an
The
ultrasound.
problem is, ultrasounds are labor intensive.
Yeah.
You need a more highly trained technician than the one that does the mammogram. And then sometimes the doctor has to come in and review it while it's happening. So it's a much more labor intensive thing. So the insurance companies don't want to pay for that. But for increased breast density, which,
Okay.
I mean, I would say, 80% of the mammograms that I read say increased breast density. It depends on if someone's high risk. If they're high risk, I have them get an ultrasound and then alternate, depends how high risk.
Yes, right.
If you're really high risk, like a BRCA person,
Sure.
if you carry the BRCA gene, then you get an MRI alternating with a mammogram, which is sad, but that's the protocol, and I can't fight that. But for the normal person who is doing everything right and eating well, I think you can go every other year with a mammogram. There's some organizations that recommend that every 3 years is okay.
Yeah.
I think one of the American College of Obstetrics and Gynecology recommended that they thought every 3 years might be sufficient, unless you're high risk.
Sure.
So I get sonograms, but I have a particular way that I've organized a particular radiology group to do sonograms on my clients without a mammogram. In general, you can't just go in and get a sonogram. I want you to first have them, okay, if you have an abnormal mammogram, then we'll do a sonogram, right? So it's a tricky area, but I definitely think that if you're good about doing your own breast self-exam and you get a good professional exam every year, that in general, you could go to every 2 years and not an annual mammogram. That's my opinion.
And what about thermography? And
Yeah.
Pardon me?
and what about thermography?
Well, 5 years ago and 10 years ago, I was doing a lot of thermography, but I had a couple patients who had a thermography every year that was perfect, and then they both ended up with breast cancer.
Wow.
And so I lost faith in it. The data and the research on it seems very good, but I personally lost confidence in it when that happened. And that's why I went to sonogram, because I wanted a non-radiation based way to evaluate my patients. Okay, so I want to talk about this slide right here. There's a lot of stuff on here. Might need a pointer, but what we want to make is we want to make this guy right here, 2-methoxy-estradiol. This is an anti-proliferative, anti-inflammatory estrogen metabolite. It's been used in quite a bit of research treating end-stage ovarian cancer and even several solid cancers, gastric cancer, etc. It's being studied for those things. And so we want to take our estradiol and our estrone, and we want to promote it across this pathway. So that first enzyme up there in yellow, CYP1A1, we want to enhance that guy. Cruciferous vegetables enhance that. And having sufficient iodine and sufficient selenium enhance that enzyme. Yeah.
And the COMT, what is that do?
Okay, we'll get to all of them. That first step there, 1A1, the advantage of it going that way is that we get this good guy, but also we decrease the amount that are going toward these unfavorable results here. So COMT is catechol-O-methyltransferase. That's a methylation related enzyme, and that is enhanced by all the B vitamins, but especially B12 and methylfolate. B6 and B2 are in there, so it's good when you're taking your Bs to make sure you get all your Bs. But if you carry the SNP for MTHFR, I'm sure you guys, most of you know about MTHFR, then you want to be on extra B12 and extra folate on a daily basis and activate the COMT enzyme, okay? Now, the one we really, really don't want is this guy down here. 3,4-quinone is a carcinogen that is shaped, it's flat, it's planar, it's shaped like a hydrocarbon, and so it can diffuse right from your cell into the nucleus of the cell. It binds to your DNA and it breaks it. Breaking DNA over and over and over again, the replication of multiple episodes of breaking DNA, of course, results in a damaged cell, and some of those damaged cells will become cancers, right? So, so this enzyme right here, 1B1, is promoted by all of those xenoestrogens. So staying away from your bisphenol A, your phthalates, your hydrocarbons, all that, you're gonna decrease the production of 4-hydroxy estradiol, which can turn into 3,4-quinone. But even if you do make some 4-hydroxy, and which we all do, you still can prevent it from going in this direction by having your methylation enzyme activated, right? And even if you make the 3,4-quinone, you can get a save from this by glutathione. This is a glutathione enzyme that neutralizes the dangerous 3,4-quinone. Wow. So, how do you get? You can take oral liposomal glutathione. You can take R-lipoic acid. All antioxidants that you take and all the antioxidants in your food will, to some degree, enhance your glutathione production, right?
NAC, is that?
NAC, N-acetylcysteine is usually it's the rate-limiting component of glutathione.
Okay.
Right? Yeah, so NAC helps, yes. So this is a milder carcinogen than this, the 16-alpha-hydroxy. And the cytochrome P3A4, that guy is activated and enhanced when you are taking a lot of pharmaceuticals. 50% of our pharmaceuticals are metabolized by the cytochrome P3A4. So if you're taking a lot of pharmaceuticals, then that enzyme's going to be activated, and you're going to make more 16-alpha hydroxy, which you don't want to do. So you can see, what I like about this is you can see really easily in a kind of diagrammatic form how the xenoestrogens, the toxins that we're exposed to, and how pharmaceuticals directly can increase your risk of breast cancer, right? So we have very good pathways. The CYP1A1, if you're not a fan of cruciferous vegetables, or if you can't eat a lot of cruciferous vegetables because you're on a FODMAPs diet or something, you can take diindolylmethane or indole-3-carbinol, which will activate that CYP1A1 enzyme.
Ann?
Yeah.
So the arrows for the COMT are pointing down, so I'm just confused there. So the catecholamiine methyltransferase, do you want to increase that with the methylation? Is that what you said?
Yes.
So, okay.
Yeah. Yeah. Don't pay attention to those little arrows. Yeah.
So just like a heads up, because as a psychiatrist, I test for all these because I'm testing for in the liver how things are metabolized and what best medication to choose from. And interestingly, when I checked for the COMT, sometimes people come out with reduced capacity, right? You probably know, or increased capacity. So it's just interesting that those that would I'm assuming then have decreased capacity would be then more, you need more methylation, right? Would that be
Yes,
a
yeah.
deduction you could?
For example, if you have a mutation in your catechol-methyltransferase enzyme,
Yeah.
then it would need more enhancement, and that person would be more dependent on the B vitamins and more B12 and more folate. Yeah. My computer, no, take back on. Okay. So, I actually test for these. There's a urine test where you can test all of these estrogen metabolites, and that's part of how I do a risk evaluation for breast cancer risk in my patients, right?
Wow. I've never
Both
seen that.
estrone and estradiol make all these different metabolites, and you can actually measure them. We can't measure the 3,4-quinone, but we can measure the 4-hydroxy, right?
Wow.
And if you have a high 4-hydroxy and a low 4-methoxy, you know that you're in trouble and you need more enhancement of your COMT
Wow.
enzyme, right? You want to make a lot of 2, you want to make a real lot of 2-methoxy estradiol, right?
You are
That is
personalizing
really
this.
great.
That is amazing. I've never,
So,
yeah, I've never seen
what
that.
lab are you using for that?
Yeah.
Can I say that?
Yeah.
So I use ZRT, David Zaba's lab. David Zaba is a researcher and owns a lab. He's been doing this research for 40 years, really smart guy. There's, as far as I know, there are 2 labs that are doing these extensive reports. Precision Analytics does a test that they call a Dutch, but they don't do as many metabolites as ZRT does for this. So I like the ZRT test.
Is that the Dutch urine test?
Dutch urine,
Yeah.
yeah, that's the one that Precision Analytics company was actually started by a guy who worked for David Zaba for many years, and then he went and started his own company. But he only does half the metabolites. He does only the estrone metabolites, those 6 that we saw, whereas the ZRT test does estradiol and estrone. You get 12 metabolites, so I think it's a better test. Yeah, so I think we've talked about, I've talked about most of these as we went through those slides. Depurinating adducts, that's the official name for when the 3,4-quinone binds to the DNA and breaks it. You can find pieces of these depurinating adducts or pieces of broken DNA in the urine. And in some research, they measure the depurinating adduct levels. And
Well, 64, but not too far ahead, too far behind.
64, okay. No, I think we've covered all of this. I think it's time to let you guys ask whatever questions you want. This was supposed to be a 45-minute talk.
You've
and I
done
think I'm
amazing.
well over that level.
You've done amazing.
Thank you.
Yes.
I just have a quick question about glutathione. There seems to be not a consensus about whether oral glutathione is effective. What have you found?
Yeah, so for many years, I was very skeptical that oral glutathione was useful, and I've actually in our office we do IV glutathione, and I've also prescribed a lot of nebulized glutathione, where the individual buys a fairly inexpensive nebulizer that aerosolizes the glutathione, and they breathe it in, usually twice a day, between 200 and 400 milligrams of glutathione. And that's a very effective way you can see increased blood levels. But more recently, there's probably 7 or 8 what I consider to be very reputable companies that are producing what's called liposomal glutathione now. And liposomal just means that it's in a form where it can be absorbed through the intestinal wall. And we're seeing, we're getting pretty reliable reports of good intracellular glutathione levels and intracellular glutathione effects. So I am using oral glutathione.
Is there a best time of day or way to take the oral glutathione? Doesn't matter.
One of the members asked me to ask you, her sex hormone binding globulin level is always out of range high. And she can't figure it out. She's fit and does everything right, and she's just wondering about that.
Well, thin women will tend to have high SHBGs. I don't know exactly why, but you don't really want a real low SHBG.
Okay.
People who are overweight and unhealthy will have very low SHBGs. SHBG just means sex hormone binding globulin. It just means how much of your estrogen and testosterone, not the progesterone, are bound to this protein. The rest of it is free. So if you have a real high SHBG, then you need to take the estrogen level higher to get bioavailable, a comparable bioavailable level of estradiol.
So what kind of ratio?
I don't know.
Okay, but generally
there's
higher.
no good research. There's no good research. But
Thank you.
if somebody has a
Yeah.
real high SHBG
Uh-huh.
and their estradiol level is 35, and so usually if your estradiol level is 35, you're not going to be having hot flashes, night
Right.
sweats. But if your SHBG is high, then you need to take it higher.
Okay. Thank you.
Just a comment on that.
Yeah.
I'm a Steve Gundry patient, and my SHBG is very high, and he says it's very common on his diet. And I have the issue with testosterone. And my testosterone level is fine. My free testosterone is low. So that's the,
Right. That's
because of the
exactly it.
SHBG.
Right.
But yeah, the diet could be part of the issue.
Yeah. Well,
And he says his is the same way. So
diet, exercise, etc.
And not eating for 3 months.
A lot of what's considered to be the normal range, on the labs, when you take the standard American person, right? And then here's our range.
Right.
I think the SHBG range might be wrong.
Okay.
If you take,
Fit
really
people,
healthy
yeah.
people who
Right.
have a really good BMI and they're very physically
Yeah.
active and they're eating a ketogenic diet,
Right.
a lot of these numbers,
Don't apply.
we may have to shift, optimal range.
Okay.
May well shift.
Why did you lower your optimal BMI?
Well, I think a BMI of 18 is probably.
But you said 18 to 22.
Yeah, I think it's better. I mean, I think it represents a better, that height to weight ratio represents, weight per kilograms per meter squared, right? I think being in the range of 18 to 22 represents a higher state of health. That's just, I don't have a specific research I can point to on that.
How accurate do you think that is, given people's different
BMI?
bone density
Yeah,
and
that's true.
muscular density and so forth?
Yeah, I'm sure there's some wiggle room in there. I'm not a BMI expert, so I'm not sure.
I was just thinking back to the sex binding globulin that, as I recall, there have been studies done when you're calorie restricted, that is going to raise
Raise.
that.
Sure.
And then reduce your free
Sure.
hormone index.
And that could be the case
And
for
so that's what
the person I'm thinking
actually
of.
for a number of us, really,
Sure,
that,
we do, yeah.
might be following more of a ketogenic or you
Right.
have,
Yeah.
calorie restriction, that it would be interesting to check all of our SPGs and
Sure.
see, as a That's, once again, the canaries in the mind, that's
Yeah,
what we are.
well, I was talking with Julie earlier about the fact that I have a number of, what I call Bredesen protocol patients, right? Who are incredibly compliant, right? And they get on the protocol and they're absolutely dedicated. I have quite a few ApoE4 patients now. And they drop their weight 20 pounds and they get their BMI goes from, 25 to 18 and they feel great. And then, maybe their BMI gets to 17.5 and they still feel great, So are we going to say that, any BMI below 18 is an absolute no-no?
Yeah.
I don't know,
Yeah.
Their
yeah.
their beta hydroxybutyrate is 7 every morning, I don't know, they're doing better than I'm trying to do the protocol, they're doing better than me,
I think the whole BMI is actually being called into question a lot in medical practice
Sure.
right now, as how really accurate it is. I think
Sure.
the weight or the waist to height measurement is
Yeah.
at least in
It's
recent
kind of like the old
studies.
scales that they used to have, that I was always 20 pounds underneath. Yeah, I mean, if I was the normal weight, I would be
Does it really take into account bone structure, which is an important?
Right. I mean, if someone is physically active, if they're out there, they're playing tennis every day, and they're feeling great and strong, and their tennis game is improving, are you going to really say, your BMI is too low? I don't think so.
Right.
So I just have, are you,
I think we need to eat, but let's have one more
well, I have one more
question.
question. I'm sorry, I'm going to monopolize
No.
some of us. But I'm just wondering if, because you did mention you have a lot of our brothers and sisters coming into you that are ApoE4 positive. So if you have somebody come in and maybe they have some, subjective memory complaint, maybe not really meeting criteria for MCI per se, they're over 60, they're postmenopausal, and they're coming to you maybe like just for an evaluation of hormone replacement. So I'm going to just assume that you would then say, well, I don't want to assume anything, I'm just going to let you answer the question. So what would you
consider?
Would you consider the HRT for that particular woman?
If she hadn't been on it previously?
Yes.
Okay.
Right.
At age 60? Absolutely.
Yeah.
Oh, yeah.
So most of your patients, and what I'm going to say, I'm assuming then, that most of your patients 60 and above are on BHRT.
Absolutely. Certainly not all.
Yes.
Some women are absolutely like, I'm scared of hormones.
But it
No,
would
I
be
don't even want to
because-
talk about it. I have those kind of patients,
Yes.
And I talk to them, I tell them my point of view, but I don't, I'm not going to
Yeah.
push it on anyone, of course.
I get it.
But, remember the Asthana study where they already had
Yeah. That was impressive.
significant cognitive decline,
Yeah.
and
Showed
they
improvement.
improved dramatically in that 8-week period, Yeah, I'm going to recommend it to someone. I'm going to recommend they find out their ApoE4 status. I'm going to recommend that they change their diet.
Yeah, we love you. And then, the $1 million question, how long do you stay on it?
Yeah.
Right? Yeah. And I know we don't know.
If we're
But what do you
ApoE4,
think?
don't we want to stay on it indefinitely?
Possibly.
I personally
Yeah.
am never going off it. That's,
But you
Okay.
know that there, like my doctor, for example, who knows I'm an ApoE4 homozygote, she would like to see me off estrogen.
yeah, but is she familiar with the research?
Clearly not.
It's very difficult. I've refused to do it, and I've
So,
gone to see other.
I run into this problem in my clinical practice every week where someone who is, between age 60 and 65, who's on hormone replacement, usually it's the people who are on the patch, and the insurance comes back and says, no, we're not
Yeah.
going to
Yes.
approve the patch anymore, you're done with that.
Yeah,
That's an issue.
You're done. So, the patch is very expensive if your insurance doesn't cover it, and I'll tell you my little secret, if they really want to be on the patch, we order it from Canada.
Okay.
6 months supply from Canada is less than a 1 month supply here.
That you pay full price.
That's how bad our system is here. Sorry to say, right? So, Thank
That
you all
was
so much.
And thank you, gentlemen, for putting up with this.
This guy was taking tons of notes.
My husband is a pharmacist, he was compounding pharmacist.
I wanted to show you this because I thought you might appreciate this. I do massive in my, aside from what I'm doing.